Sir, good afternoon, sir.
Good afternoon. Good afternoon, Dr. Sheehan Syndrome, President IMA.
Thanks, sir. Thanks.
Murali? Murali?
Sir, good afternoon, sir.
Good afternoon. We shall start or?
We can start, sir, as per our protocol, sir. We can start, sir. As of now, 22 doctors have joined, sir. So probably another few minutes will get joined, sir.
Suresh, 1 minute. I'll just welcome.
Sure, sir.
Our guest of honor.
Dr. Kaushal Ram, sir, IMA Joint Secretary.
Okay, Kaushal, I know.
Yeah.
On behalf of Sri Ramakrishna Hospital, I welcome the President of Coimbatore branch of IMA, Dr. Sheehan Syndrome, and Dr. Kaushal Ram, Honorary Secretary, and the senior consultants inside Ramakrishna Hospital and from outside, and other practicing doctors from the city of Coimbatore. I welcome all of you for this fortnightly webinar conducted by Sri Ramakrishna Hospital. And last year, this last 6 months, our IMA president gave a strong support to all our webinars, and he allowed us to conduct all the meetings under the banner of IMA. I thank him for that. And on behalf of Ramakrishna Hospital, we all congratulate Dr. Shanmugam for receiving the Best President Award nationally and also statewide. And he has bagged more than 25 awards for his branch. We all congratulate Dr. Shanmugam, President, for his achievement. And we thank him for allowing us to conduct this webinar under the banner of IMA. And today's speaker is Dr. Suresh Taumaran. He is senior diabetologist and endocrinologist. He was trained in UK, and he had his MRCP and CCST in general medicine, and also in diabetology and endocrinology. And he is the current vice chair of the Endocrine Society of Tamil Nadu, and the executive council member of Endocrine Society of India. And recently also he has conducted a webinar web conference wherein a record number of more than 9,000 registrations happened, and it was a tremendous success for him. And today he talks on how to diagnose and manage pituitary disease, which is a very useful topic for general practitioners and also for consultants and physicians. Dr. Suresh Taumaran.
Can you hear me, sir?
Yes.
Thank you very much for the wonderful introduction, and I thank from my heart Dr. Taumaran, our dean, and he's been with me for all the educational and academic activities since he induced me to Ramakrishna Hospital about 4 or 5 years ago. And thanks very much for the marketing team to come up with an idea, and thanks for IMA and Sir Shanmugam sir, know most of them. Thank you very much for joining us and being part of our academic activity. And I think it's just good of us just to be with the current corona pandemic and everything, lot of webinars and everything happening. And if you have a good content of knowledge, good content of the medical content is there, a lot of people are joining, and it's becoming, people thought it's a disadvantage, but it's more of a knowledge gaining platform. Nowadays people sit at home and just gaining the knowledge, and it's amazing thing that's happened with the corona. So corona has brought in a lot of positive things as well. So with that, I think if I can share the screen. Can you see the screen?
No.
No, sir. Okay. Sure. Can you see, sir?
No. Yeah. Now it is
visible. Okay.
Yeah.
Okay. So what I thought is when the marketing team came up with an idea, and instead of just going about beating around the bush of what we have done and what are the things that can be done, instead of that, just a basic knowledge of the common diseases. People think it's an uncommon disease. Yes, it is uncommon if you don't open up the eyes, and if you do open up the eyes, there will be pituitary disease is not uncommon at all. I think with the population of more than 5 lakh or 30 lakh population in Coimbatore, I'm sure there is quite a lot of pituitary disease. We were talking with the cardiologist this morning. It is mainly that people have to just diagnose this condition and then refer to appropriate team. But it's just the amount of investigation that we tend to do is sometimes minimal than what it should be, if you know what I'm saying. So I think if we suspect somebody very abnormal, and the things that you cannot diagnose by always, hormone tests will be very, very helpful tool actually, because endocrinologists getting patient directly will be a challenge. But I think once we go work as a team, and it should be there. So this is my flow of talk, and if I can go through within 25 minutes or so, that'll be useful. So we know this hypothalamo-pituitary axis. So if you look at the hypothalamus, which is the topmost control in the body that controls the pituitary gland, and then the end organs comes in: thyroid, ovary, testis, growth hormone goes into the IGF-1 pathway and through liver, and it acts on the skeletal muscle and everything. And we got prolactin, and then we got the posterior pituitary, which controls the water balance. So we got anterior pituitary and posterior pituitary, which takes care of the whole body, in fact. And other hormones are produced in the fat, which is now becoming like a big thing, that the fat cells are producing adiponectin and leptin, and other organs like liver, and also adrenal cortex and ovary and testis, these also produces hormones. But the main control of the hormones will arise in the hypothalamus and pituitary gland. So we know that. I think this is the thing that, for example, I'll just give you a small example. So hypothalamus produces TRH, which is thyroid releasing hormone, and the pituitary gland releases thyroid stimulating hormone, which is the TSH, and then the thyroid hormone comes in and the thyroid gland works. So this is the thing. So when the thyroid hormones of T3 and T4 is in excess, then it got a reverse negative feedback, so that the TSH comes down, and then the TRH production also comes down as well. So like that, I think just this is for the cortisol thing. I want to bring up a couple of examples for you. That picture was quite complex with all the hormones in the picture. This is the one that I was talking about. It's just quite a lot of all the hormones have been in the picture. But if you look at the gonadotrophin axis, there is a GnRH, which is produced from the hypothalamus, and then LHFSH from the pituitary gland that works on the Leydig cells and tubules to produce hormones. For example, in a male, it produces testosterone and the spermatogenesis happen, and in the female, it produces estrogen and progesterone, so that the cycles and fertility and the whole lot happens in the female. So with that introduction, I want you to understand that the whole control is from hypothalamus and pituitary that goes into the end organ and works. So we are talking about the exciting gland, which is the pituitary gland, which is got amazing control from the feedback and also from the hypothalamus. So with that note, so what we normally tend to do is, if we find out an excess hormone secretion, it is a vast topic of its own. Pituitary is like a massive topic on its own. I cannot say the whole lot. So what I thought I'll conclude is excess growth hormone, we know it's called acromegaly. And the simple thing that you need to know is, when it's functional and it's become very active, the surgery is going to be the mainstay of treatment. And then example of ACTH secreting, which is the Cushing's, which is more of pituitary dependent Cushing's coming out of the pituitary gland, and the surgery will be the thing. And you do location of the tumor by IPSS or desmopressin test, or whatever it is you can do just to locate the tumor, and then get the surgery done. And excess TSH secretion from the pituitary is called TSHoma, and prolactin, which can be managed by a physician with a dopamine agonist, which is hyperprolactinemia. When it comes to macroadenoma, it's quite large tumor, then it has to be surgery, and especially when it compromises, when the pituitary is near the optic tract, so when it compromises the visual tract, then it has to be surgery. That is the mainstay of treatment. So for a physician, I would say, when you get a blood result in hand, the result shows hypopituitarism, how to go about it, and what are the things. So I've showed you the excess thing, which can be managed by surgery, but what happens to the hypopituitarism, which may be the only diagnosis, and how to approach that. I will just touch base upon this one for today. As a physician or a GP or a student, that we need to understand this one, and I'll show you some exciting cases on the way, so that you understand much better. So hypopituitarism is called Simmons disease, and I will talk about only Indian data. I don't go into the Western data. So Indian data is the one that will help us. Whatever it is, the Indian data is very, very scant. People like us, we have to contribute, but I think with the amount of patients we got, it might be very challenging to contribute, but we can still contribute. In our department, we contributed a lot in way of doing a case presentations in various endocrine meetings. So in 75% of the pituitary get damaged in hypopituitarism, and the main thing with hypopituitarism is pituitary tumors and Sheehan syndrome, pituitary apoplexy, which is not at all uncommon, pituitary infection, hypophysitis, and traumatic brain injury, which our hospital has got an excellent department which can handle it. So the main hormone productions are ACTH, which causes an ACTH deficiency, thyroid stimulating hormone, which is called hypothyroidism, gonadotrophin deficiency, and also growth hormone deficiency can happen. The exciting aspect is that adult growth hormone deficiency is also common when it comes to pan-hypopit. But in India, because of the cost of growth hormone, anywhere in the world, it's very expensive. But in India, patient has to pay from the pocket. So adult growth hormone deficiency is not, even though it is diagnosed, it's not treated sufficiently. And ADH deficiency, of course, it's a posterior pituitary hormone, which can lead to imbalance in the water. So it needs a desmopressin as a oral meds or tablets. I think there was a recent scarcity of oral desmopressin happened as well. And when it comes to bitemporal hemianopia, we know that we need to act on very quickly so that we can get the tumor which is pressing out, so that we can act upon it. So hypothyroidism, what are the challenge, what are the examination findings that you can get? It's a very common thing. I don't want to go into the details, but normally it's cold skin, pitting edema. You may not have anything at all. And adrenal, you normally have a buccal pigmentation. Hypogonadism, what happens is normally the axillary and pubic hair can get involvement. And then I mentioned about ophthalmic and neurological case of involvement, so that causes bitemporal hemianopia. So it can be like this, or it can be anything relating to the end organ levels, hormone end organ level. So when it comes to hypopituitarism, this is the diagnosis that normally we end up on, but we should isolate and diagnose properly so that we can have a accurate management. So hypopituitarism can be due to pituitary as such damage, or second to hypothalamic damage, which can be a road traffic accident or anything like that. So isolated pituitary damage can happen, or pan-hypopit, which is like a whole hormone damage, can happen. So these are the common causes. I won't go into the details, but in our hospital, the pituitary tumor, even in the Indian data showed pituitary tumor. I'll show the Indian data very, very quickly. I don't want to go into the research aspect totally because it's a clinical one. So a lot of students and a lot of clinical practitioners are there. So, but pituitary tumor is the main thing. And then if you go to TSH, which is like a transsphenoidal hypophysectomy can be done, and transcranial surgeries. Once it's done, then the people end up with an hypopituitarism. And pituitary apoplexy, as I said, it can come as a severe headache. It can present, and then you do an MRI, you can show a pituitary apoplexy. Initially, it won't be showing much in the MRI imaging, but in later stages, it can be meningitis and hypophysitis. I'll show you a couple of case reports that we have done, and also hemochromatosis, which is not diagnosed properly, but it's also incidence is very less in India. So congenital causes are there. I won't go into the details, but I think this pituitary tumor is the very common one. As I mentioned, in India, the data is done. Army Hospital, the pituitary macroadenoma is the commonest cause for hypopituitarism of 75%. And vision disturbance was the common features that happen in the hypopituitarism as well. But I think if you look at the hormone deficiency, mainly hypogonadism and hypothyroidism were the top in the list. But adrenal comes in next, growth hormone deficiency. This is the Indian data. But gender-wise, I think males are common compared to females. And also, if you look at the amount of treatment approaches that has been done, surgery and surgery radiotherapy and surgery with gamma knife surgery was the way forward when treating these patients. So with that introduction, I've showed you how the hormones works in the first half of my presentation, and second half, I showed you the excess hormone production will lead to various conditions. The surgery is the treatment, and but common physician or a junior doctor, we need to focus mainly on hypopituitarism, which is just a simple blood test. And once it's happened, I showed you the causes that has happened and what is the commonest causes in India. So that is very clear. Now, coming to the cases, so I want you to understand these 4 or 5 cases, what I'm showing, and that will, if you just picturize and keep it in your brain, so it will be useful for your future when you do the practice. So 23-year-old male, this came to our clinic about 2-3 weeks ago. Dr. Palnisamy, our urologist, referred. General examination showed absent secondary sexual characters, micropenis. He's 23-year-old. He's working in a shop. He started on levothyroxine treatment already by a general practitioner, and he was sent to Dr. Palnisamy for his small penis. So this guy is waiting for an MRI because of financial thing. But I think if you look at the gonadotropin, LH levels are less than 0.2, FSH less than 0.66, and testosterone of less than 0.3. So you got the reference range in this side, and you can see the levels are extremely low. So we got the gonadotropins, which is LH and FSH secreted from the pituitary gland, is almost negligible. But if you look at the testosterone, levels are 0.3. That means when the testosterone levels is less than 0.3, then LH, FSH should be secreting in excess if pituitary is working well. But in this case, you can see the testosterone levels are also less. LH, FSH levels also less. So that indicates itself it is something to do with hypogonadotrophic hypogonadism. So that is pituitary also production is less, and gonads is also less. So that is one diagnosis. And you see the prolactin levels also in the lower end, and TSH, free T4, free T3, all the levels are in the lower end of normal. Cortisol level, even though it looks normal, but it is not normal when you replace other hormones. So patient is diagnosed to have pan-hypopituitarism. That is the diagnosis we made it. And then cortisol, testosterone, and thyroxine dose all was adjusted. So this is the case which came in 2 weeks ago to our OP. And this is what we are talking about. 23 years, until 23 years, nobody got this diagnosis. So you can open up your eyes, and I'm sure you will get it a diagnosis. It's not uncommon. There is another condition called empty cella syndrome, which if you patient get admitted for a surgery or something for any other condition and you can't explain few things, if you do the pituitary hormone profile, you will establish that they may be deficient of some hormones in a minor way. So this is my case, second case, 67-year-old male, 2 months history of nausea and vomiting and tiredness and dizziness and decreased appetite. So we got a tired patient vomiting. If you look at in your clinics, if you get this kind of patient who cannot explain anything, please do a pituitary hormone profile. Weight loss of 2 kilos is there. So lying standing blood pressure is done, 20 drop of systolic blood BP. As you know, it has to be more than 30 to diagnose a postural hypotension. But the patient is not tachycardic, respiratory rate is 18 per minute, and sodium level is 120. So how many times you have seen sodium levels are very low in the ward and thought about, okay, it could be a hormone deficiency. You should think about it, because if you don't think and don't investigate, you cannot get any endocrine diseases. So urea was normal, creatinine was 1.3, and LFT is in the normal side. We got a sodium less patient here with 20 drop of BP. So 2 admissions, what people have done is just intravenous saline, some improvement, patient goes back. Because of vomiting, patient has done had an endoscopy and an ultrasound, which is all in the normal limits. You got a osmolality, serum osmolality low and inconsistently high urine osmolality. So we got serum sodium level of 120, glucose of 104. It doesn't show much in that picture, but however, if you do a TSH level 1.4, which is I'll come to that. If you look at the free T4 level, I'll make you understand. So if your free T4 level is very low, so free T4 level is low means that the TSH, which is from the pituitary, the TSH level should be high, because it's a negative feedback. However, here in this case, the TSH levels are normal. So that indicates itself there is a problem in the pituitary gland, which is the secondary hypothyroidism is there. On SST means short synactin test, you can see the levels are not very, very high. When you give a synactin, which is an ACTH, If you give ACTH, you're not seeing any levels of rise in the cortisol level, indicating a secondary hypocortisolism. And also, if you see the gonadotrophin levels, LH 0.4, FSH 3.8, and patient has got bitemporal field defect. So we got a diagnosis without doubt. So you can say, by seeing the TSH, you can say, doctor, these levels are normal only. Why you're saying is a hypothyroidism? But if you look at the free T4 and free T3, you can interpret the readings better. So whenever you ask for a TSH and we are confused, ask for a free T4 and free T3. You can get the diagnosis, whether it's a secondary cause of hypothyroidism compared to the primary one. So when you did, when you do the MRI scan, you can see in the visual fields bitemporal hemianopia, with a massive pituitary tumor was there. Patient was replaced on hydrocortisone, thyroxine, and symptoms settled in 2 days. Sodium is 140. Patient went home. And TSH, which is the thyroid transsphenoidal hypophysectomy, is done, and patient had a good recovery, amazing recovery. You can see the visual fields completely recovered. This is like a miracle when you diagnose it, and patient will feel so much better when you replace all the hormones, and it's a good feeling, and patient will not go back out of you. Once you replace the hormones properly, they will come back to you very promptly. So 59-year-old is the third case, found unresponsive in bed, and tiredness, constipation, temperature is 95, bit hypothermic, and heart rate is low, and we got no postural hypotension. So we got a hypothyroidism without as a clinical diagnosis. What happened is we did the blood test, and TSH is 1.4 with free T4 levels are in the lower side. So as I've explained earlier, once the free T4 level is in the lower side, you expect the TSH to be in the higher side to diagnose a primary hypothyroidism. But here, in this case, the TSH levels are 1.4. IT team, can you mute everyone, please? Murli sir, can you ask IT team to mute everyone, please?
Yes, sir. We'll look into it.
Thank you. So the anterior pituitary, if you look at the other hormones as well, LH, FSH, all in the lower limit, and prolactin is very low, and short-chain showed not much of response when it comes to the cortisol, and IGF-1 shows lower level. IGF-1, for that matter, those who are not familiar, IGF-1 is insulin-like growth factor 1, which is the way that growth hormone works. So if you want to monitor the hormone, growth hormone levels accurately, then you have to do IGF-1 to elicit growth hormone. You can ask once why in an adult you want to measure a growth hormone. You really need to measure because a lot of symptoms could be due to growth hormone deficiency. I will come to that in a later stage. So this is the patient that who came in. So the most likely it could be a pituitary infarction or an apoplexy. So it is an amazing case. So you need to understand a pituitary tumor could be the reason, and secondary pituitary apoplexy could be another reason. So next one is the lymphocytic hypophysitis, which is like a pituitary tumor which can happen because of IG4 infiltrates or anything autoimmune etiology. So we published when I was in University College London. Then these are the case reports that we have done in the endocrine abstract we got published. It's a postpartum, peripartum patient came in with visual field defects, and then we have diagnosed this lymphocytic hypophysitis. It's not uncommon at all. I think we need to open up our eyes, and we can see that. So it's an autoimmune etiology, and this patient has responded to steroids beautifully. And what happens is when you give steroids to this condition, it melts away like anything. So you don't need to do even surgery at all. That is why as a physician, we need to know this diagnosis. You should not think it's a very rare condition and then get away. But once you got this diagnosis, I'm sure patient will be very grateful if you save them 2-3 lakh rupees. And then moreover, I think you can get a complete cure for these patients. So another case we published is a case of extra pancreatic manifestation of autoimmune pancreatitis, which is never happened, case reported before, which is like autoimmune pancreatitis is a condition. It is like a pancreatic tumor. It will be normally, But in this one, that Ig4 infiltrate, which is an autoimmune etiology, presence in the pituitary gland to show this is the guy, that 62-year-old chap. When I was doing rounds, I think we picked up in a post clinical meeting, and this has been presented, and it is almost presented in the Pituitary Foundation, and it's been almost the first case report. It's got amazing sort of eye opener for a lot of people, and people came up with the case series after that. So this is the case I was speaking about. All the hormones were very, very less in this case of autoimmune pancreatitis, and you can see in the pituitary gland in the sagittal view all this kind of white kind of stuff infiltrated into the pituitary gland, which is called lymphocytic hypophysitis. That is because of Ig4 from the pancreas as deposited in the pituitary gland. This is very interesting case. This everybody should know. It is like a 40-year-old lady presented with intensive care with hemorrhagic shock due to postpartum hemorrhage following normal delivery, and transfusion 5 cross-match blood happened and replaced with hypertonic glucosaline hormone profiles was done, and then the lactational failure and hypoglycemia crisis happened. This patient was presented to me when I was in KMCH. Actually, this patient went to almost 5-6 doctors. He was depressed. He's the only lady in the house, only child in the house. So, and she almost got divorced from the husband because she was not looking after the kid after the delivery. And what happened is the patient was almost isolated from every one of them, vomiting, feeling weak, depressed, down, everything. So this is all happened postpartum, and she was not feeding the child. So this is a condition called Sheehan Syndrome. Most of you will know Sheehan Syndrome. This is very, very important diagnosis to make. Once you got the diagnosis, you have to, it is like a cakewalk. Once you got a diagnosis, you really can treat the patient well, replace it with thyroid and hydrocortisone. And Sheehan's is a condition, it's like more of a vascular thing. It can be immediately after postpartum hemorrhage, or it can lead to after some time, after during the postpartum period, after a few months it can happen. But if the prevalence is almost 2.5 to 4%, in Endocrine Society India, we got our ex-president who was from Kashmir, who's done the work on it. He's done Abdul Zargar. He's done amazing work in Sheehan syndrome. The incidence is very, very common in that part of the world. This is the data that I was talking about, epidemiological aspects. This is the Kashmir Valley in the Indian subcontinent. It's published in the Fertility Journal, and it shows he's clearly came up with which are the things that hormones went off first and what are the things to be done. So this is from Bangalore. This is from Kolkata. Sorry, this is a review of 18 patients. It shows that it can present as an acute emergency or a chronic ailment. So Sheehan syndrome can present immediately after the postpartum delivery, or it can present few months later. That's all you should know. You should open your eyes and just do a pituitary test, and you will get the diagnosis. Once you got it, you cannot. This is the one I was talking about, and from Bangalore. It is. This paper was published in IJEM, which is an Indian journal, which has got the maximum hits now in the world, one of the maximum hitting journal in the world. So case 6, this is my almost the last case that I want to show. A 42-year-old with a 10 years history of generalized weakness, lethargy, coarse facial features, and reduced libido. He's got, this is the thing that you should know, whatever you practice. Acute illness following a snake bite. So you might be wondering why we're talking about a snake bite in a pituitary, but if you look at it, the altered sensorium, acute renal failure requiring dialysis all happened, and he was managed by a physician, and his symptoms persisted, and he was diagnosed to have hypothyroidism at that stage, and he was treated on levothyroxine. But I think it is a secondary hypothyroidism. I've explained to you with first two cases. that how to diagnose a secondary hypothyroidism. It's been overlooked in the previous 10 years. So that you look at the September 2002, 0.84, 0.12, 0.00 in this OP. But so it has been completely missed. It is a secondary hypothyroidism. Patient was replaced on thyroid hormone. But if you do the other hormone profile, you can see patient is a pan-hypopit. So what happened is pituitary revealed an empty cella, which is the cella is almost empty. A patient is replaced with hydrocortisone, thyroxine, testosterone gel, and bone density was done. So this is to show that snake bite can cause a pituitary dysfunction in a big way. Again, it is like Sheehan's, it can present acutely or it can present later. So just because of the vascular involvement, we don't know the exact mechanism, but in India and Sri Lanka, in other parts of the world where viper snake is there, it can cause a pituitary dysfunction in a big way. So we had I dealt with almost 8 to 9 cases when I was in KMCH. But this hypopituitarism patients can present very acutely while they're doing the first initial dialysis itself. They can drop the blood pressure and you have to diagnose it. This is like because it's a new concept in the world, so we have to give from India more data. So that is the exciting area. This is a Calcutta troop. Few of my friends from Calcutta, they did the paper just showing that how bad it can be managed if you don't know the diagnosis. So delayed hypopituitarism can also happen following a Russell Viper innovation. Now I think again Sujay Ghosh and team are presenting, have sent this thing to Pituitary Journal and last month, and hopefully that gets published. That will be a big data to show. I've spoken about the pituitary apoplexy, but it's not uncommon. It is a usually vision-threatening diagnosis. And then other condition for India is the TB thing. So TB with TB, lot of abscesses develop in a big way. Among that, pituitary abscess or the suprasellar abscess can happen. So you have to look for carefully for the pituitary dysfunction. This is our endocrine president Sanjay Kalra has published this data when it's about the tropics, diseases in the tropics. So with these 5-6 cases, what I've shown, the first case is about knowing it's a pituitary tumor that has caused hypopituitarism. So when you do have somebody unexplained headache, this thing, you want to do an MRI, you just do Sheehan pituitary mass, you do other pituitary function test to see the diagnosis. And I've explained to you how to diagnose a secondary hypothyroidism. When you look at the free T4, free T3 levels are low, you expect the TSH to be high. But on the other hand, if it is also low, you got the diagnosis, or it can be normal as well. So in that case, that it's not responded to the low level of FT4 and FT3, so that it is called secondary pituitary failure. So, and then the second case I've shown you is pituitary apoplexy. There is a bleed in the pituitary. Patient came in with a headache and not doing well with the vomiting and other things. So ended up in having an MRI which showed pituitary apoplexy. But I think the main thing is you can ask how we can deal with it. As a physician, we should be very careful in just replacing the hormones. And then the third case I've shown you is the Sheehan Syndrome, which is like a postpartum pituitary apoplexy. Apoplexy is bleeding. So apoplexy, it's very important to diagnose this condition to make a management, and it can present very acutely immediately after the postpartum hemorrhage. When a lady has got a lot of bleeding postpartum, they can have a pituitary apoplexy. We should be opening our eyes and looking at it. And then the fourth case, I was just showing about the lymphocytic hypophysitis, how an immune-mediated disease can be presenting as a tumor, and then it can cause hypopituitarism. But if you give steroids, they will respond beautifully. And the fifth case I've shown you is the snake bite, which is very common as a snake bite in India. But to diagnose a hypopituitarism, you have to really know this condition to diagnose it. Otherwise, we'll miss out. We'll be seeing there is unexplained BP drop, and we'll be doing something hemodynamically, pushing more fluid and everything. Nothing will work. But on the other hand, if you know this diagnosis, you give cortisol, BP will be maintained, and other hormones, if you replace adequately, it will be there. And in India, the other things to think about is the snake bite, and pituitary apoplexy is another one to think about. For all other people who deals with medication, so for physicians, other people that are rheumatology and new other drugs are coming in, the bio drugs like infliximab or rituximab or VEGF1 inhibitors and quite a lot of other new drugs. It can also cause some pituitary damage, but I think you have to watch and wait for the space. Again, with the new COVID, COVID is affecting a lot of endocrine glands, and there is yet to be published with proper data of pituitary involvement, but thyroid involvement is also there with the COVID. So with that, I think hopefully I've given you the basic explanation of how the hormones works. And then the second thing is all the high secreting thing with the hormones going excess, like Cushing's, acromegaly, or TSHoma, or prolactinoma, it needs the surgery. But on the other hand, hypopituitarism, I've explained the way with 5 or 6 cases so that you will not forget. And so you can do anything for getting a diagnosis, but I think we need to find out what our patients thinks. And when you do over investigation, also people won't come to you. Just to summarize that excess hormone secretion is mostly surgery. And I've also mentioned that pituitarism, hypopituitarism in India is pituitary tumor. Visual symptoms can happen. And I've also mentioned about Sheehan syndrome and snake bite. We can do a diagnosis and treatment. If you do a proper diagnosis, you can treat very well. Thank you. Any questions, I'm happy to answer them.
Any interaction from the audience?
Hello, sir. What is idiopathic hypophysitis, sir?
So it's hypophysitis is inflammation of pituitary gland, sir. So normally what happens is the lymphocytes, which can be an IG4 infiltrate, that can cause like a massive pituitary tumor, and it can cause just visual field defects or anything. So, but it can present as a pituitary tumor, or it can be present as just a hypopituitarism. But it will respond very well to steroids, sir. But it's very good question.
Is it a curable one, sir?
Yeah, it can be treated properly. If you almost all the pituitary disease are curable. Curable is the not the right word, but I think we can do something about it, like unlike other conditions, except pituitary carcinoma, which is very, very rare.
Like hypothyroidism, we have to replace the hormones, external like oral hormones we have to go for that, no, sir?
Absolutely.
Pituitary. Okay.
Absolutely.
So we can treat that, but we can't cure that. It's like diabetes, hypertension, like kind of disease it is. Is it so, sir?
So what it is one way true, but it is a hormone that is deficient in the body. So it is a it is like a diabetes and other things. We are giving external treatment, but here it is a deficient of hormone due to some other reason. We just replacing the hormone which God has given to us. So it is a replacement.
Yes, sir. Okay. Thank you, sir.
Any other questions, sir?
Any other questions?
Sir, have you come across any psychiatric disorders secondary to pituitarism?
No, I think it's a very good question. I was talking about the Sheehan Syndrome patient. The psychiatric presentation, this girl, this lady went into psychosis, proper psychosis and depression next to after the delivery. So she was isolated inside the room because her behavior was completely erratic. And as I said, that she was the only child in the family. So the villagers, she lives in a village, and that husband understood to an extent. 1 month, 2 months, he can understand. But after that, he could not understand why she was behaving, and he wanted to leave her through divorce. But almost 6-7 doctors, it ended up in a hand of endocrinologists. But fortunately, we managed to diagnose and treat. So your answer to your question is absolutely true. It can present as a psychosis or a depression. Not only Sheehan syndrome, but a lot of other endocrine conditions can present as a psychiatric manifestation. And I'm sure you're asking this question because you might have seen some of your loved ones or anyone who's got a diagnosis like this. But anyway, thanks for that question.
Sir, according to the latest DSM-5, there is no ruling out of other things. They directly diagnose it as a psychiatric disorder. So, as an endocrinologist, so is it required that all the tests should be done before diagnosis?
See, my way of teaching, I've been taught that if you can diagnose somebody functional, which is like a psychiatric disorder, so before doing that, you have to give all the possibilities of them having the test done properly. So you have to rule out organic causes first. Any court of law, when you stand up and ask, have you ruled out a diagnosis of organic cause? If you say no, then you won't be, you push somebody for a psychiatric counseling before ruling out any organic cause. I think that is even a mistake, actually. Normally, when I was in training, we mixed up two erratic behaviors of patients. They behave extremely badly to you. And at one stage, it just turned out to be a frontal tumors in the brain, you know. So you can get really deviated from your this thing if you don't rule out organic causes. So in any court of law, you can explain to them if you just do some pituitary hormones, at least to baseline, to know that you ruled out this thing, and you will be fine in the court of law. Otherwise, you will be in trouble.
Thank you, sir.
Welcome. Any other questions?
Dr. Karna. Welcome, Karna.
Madam, சொல்லுங்க madam. Madam, unmute பண்ணுங்க madam. She's not unmuting, sir.
Yeah.
She's talking, I think.
He's talking. Karna, you have to unmute your mic.
Is it unmuted now?
Yes, madam. Yes, madam. We can hear you, madam.
Yeah, it was a nice presentation, but still, Suresh, for a normal patient, for office, வந்து இந்த பேஷண்ட் இப்படி இருக்கும்போது நார்மல் இது கொஞ்சம் அப்நார்மாலிட்டிஸ் என்னென்ன எல்லாம் அப்படின்னு அப்புறமே இருக்கிறது கொண்டு போனீங்கன்னா ஈஸியா இருக்குன்னு எனக்கு அந்த பர்டிகுலர் இது இல்லாம what do you with me, Suresh?
Madam, I couldn't hear you scatteredly. I could hear you, madam, but I can't hear you fully.
Can you hear me now?
Yes, madam. Yes, madam. Yeah.
I said it was a very nice presentation. But still,
thank you so much.
Point of view and also from other specialties, இன்னும் கொஞ்சம் ரொம்ப ஒரு டவுன் டு ஒரு பேஷண்ட் இப்படி இருந்தா இந்த மாதிரி வந்தாங்கன்னாக்கா இந்த மாதிரி what all you have to think. இது ஒரு நார்மல் இது அப்நார்மல். ஒவ்வொரு சிஸ்டம் வைஸ் ஹெட் ஒவ்வொரு இதா எடுத்துட்டு அப்படி போனீங்கன்னா எங்களுக்கு அதை பிக்கப் பண்ண ஈஸியா இருக்கும். யூ சே we need to pick up the science.
Yes, madam. Yes, sir. It is, yeah.
எல்லாமே பண்ணும்போது ஒவ்வொரு இது இந்த மாதிரி இப்படி வரும்போது இது இந்த மாதிரி ஒவ்வொரு so that is
you're talking about case scenarios and how to it is like a module mari pannanum madam. So I think you're right in that like headache arunchina, how you go with a headache and you deal with it and think methodically. That is like a symptom based approach, madam. In even medical schools foreign country they are coming up with these kind of ideas, but it's a really good suggestion when you have a symptomatology related thing. If a visual fields defects na what are the things, if you got eye problem then you can deal that way. But what I've done is like a whole pituitary present pandrathu. It is a massive topic. So I could come up with 5-6 cases where hypopituitarism think panna or Sheehan so idella think pannanga. I think that is the point that I want to drive, and if 4 or 5 points எடுத்துட்டாங்கன்னா போதும் மேடம் இந்த presentation.
இந்த மாதிரி இருக்கும்போது நீங்க என்ன பண்ணிடலாம்னா hypopituitarism என்னென்ன how can they present with symptoms தனி சயின்ஸ் தனி ஹைப்பர் எப்படி அது முதல்ல ஒரு கொஞ்சம் அப்படியே சொல்லிட்டீங்கன்னா அப்புறம் நீங்க அந்த சினாரியோ போடும்போது பிக்கப் பண்ண முடியும்.
அது எஸ் மேடம். அது வந்து இல்லைங்க, இது வந்து தியரி இருக்கிறப்போ அது மாதிரி பண்ணலாங்க. இப்போ நம்ம ப்ராக்டிக்கலா நம்ம எக்ஸ்பீரியன்ஸ் சொன்னோம்னா உங்க பாயிண்ட் நெக்ஸ்ட் டைம் வந்து we can just show symptoms அது பண்ணி பட் எல்லாமே ஆரம்பிக்கணும், குஷிங்ஸ்ல இருந்து எல்லாமே பண்ணணும் மேடம். பட் I think it's a huge topic, but we'll try to do some other, if it is causing interest we can do modules madam. But I'll discuss with Dean sir and do it.
Okay Suresh.
Thanks madam.
President, thank you for asking him to attend this. It was nice, really very useful.
Dr. Durekanan sir, welcome sir.
Sir unmute பண்ணுங்க sir. Madam mute பண்ணிக்கோங்க madam.
The secretary of IMA.
Sir வணக்கம் sir. Sir unmute பண்ணுங்க sir. Unmute அமுத்துங்க sir.
Sir, Dr. Durekanan, you have to unmute your mic, sir. No, you are not audible.
Now audible, sir. Now audible,
right, sir. Sir, thank you. Good evening, sir. Good evening.
Good evening, sir. Thank you for joining, sir.
Out of station, entering into
no problem, sir.
I'm sorry, no I'm not able to join in time.
No problem, sir. ஒன்றும் பிரச்சனை இல்லைங்க சார். நெக்ஸ்ட் டைம் ஐ திங்க் வில் கெட் யூ இன் சார். சார் ஹவு டு யூ ஃபைண்ட் திஸ் இனிஷியேட்டிவ் சார் ராமகிருஷ்ணா டன்?
மீ
ஆமாங்க சார். இல்லை இந்த இனிஷியேட்டிவ் இப்போ IMA
we are always with you for all this academic activities.
Yes sir.
It is a good initiative. We can join together in the future.
Yes sir.
And we can work out in all our exercise, not only for the super specialties but also for the general practitioners also. Suresh sir, you can arrange every month or every 2 months and we'll join with you.
Yes sir. Thank you sir. Thank you very much.
We're very happy and we're very thankful to you, Suresh sir.
Yes sir. Thank you sir. Thank you sir. Sir, President sir. Dr. Sheehan Syndrome, please.
I think our joint secretary has joined here.
Yeah.
Yeah.
We have addressed, sir.
Coshal Ram is with us,
Yeah.
sir.
Already addressed.
Am I audible, sir?
Yeah. Audible.
I have a question, sir, for the speaker.
Yes, sir. Please tell me. Yeah.
Yeah. As ophthalmologists, usually these pituitary lesions come to us very occasionally, and we come across this particular entity called empty cellular syndrome.
Absolutely.
And it so happens that this particular thing alone is being not diagnosed for a long time till by us. And can you tell us some points like on what are the clinching factors for empty cellular syndrome?
So I'm glad you brought up this one. Actually, I don't know whether you listened to my talk, and I was mentioning exactly the same thing in my talk. I was mentioning that empty cella is not being diagnosed properly because people come with some other thing. Here alone in Ramakrishna, I got about 6-7 empty cellas. It is being diagnosed only because I happen to see the patient for some other reason. And we end up in working up and doing LHFSH and cortisol, and then you pick up with an imaging after that. So it is very, very difficult because the incidence of empty cella is not uncommon. It is there, and people present to various departments with various symptoms, maybe a vomiting or excess tiredness, a small amount of BP drop, lower end of BP drop, visual symptoms. They can have anything, but the challenge is to diagnose. So how to make people aware of get the diagnosis? It's through education only. The only way is the education, nothing else. We cannot, it is like opening the things that your brain knows only the eyes can see. So it is purely that it has to be with the education and a lot of meetings that we have to do. But you brought in the right point, sir.
Thank you, sir.
So, but when you see an empty cella in the imaging, that you have to do the hormone levels accurately in empty stomach, LHFSH, and then interpretation should be happening along with an endocrinologist. So you can see which is normal and abnormal, not like straightforward. You see a normal limit and then you say it's normal and it's okay. You should not do that. So you have to look at the testosterone. If it is in the lower end of normal of 190, but still in the normal level. But if you look at the gonadotrophin, it should be in the higher end, but it is not in the higher end. Then you think about this diagnosis. It's like a partial empty cella or whatever. So there are a lot of things to the hormones actually.
Okay.
Thank you for bringing that.
Thank you, sir.
சார் சொல்லுங்க சார். சொல்லுங்க சார். சொல்லுங்க சார். கேக்குது சார்.
ஆரம்பிச்சிருக்கலாம்
சார் கேக்குதா? சார் கேக்குதாங்க சார்?
சுரேஷ், சுரேஷ்,
நான் கேக்குதுங்க சார். அவர் சார் கொஸ்டின் கேட்டிருக்காரு சார். எனக்கு அது கேட்க மாட்டேங்குது. அவரோட போன், அவரோட மைக் அப்ளை வந்து ட்ரபிளா இருக்கு.
யார் இவரு? பிரசிடென்டா?
ஆமா, கையில காட்டுறாரு பாரு. நல்ல ஏதோ கேக்குறாரு சார். டாட்டா காட்டிட்டாரு. முடிங்கன்றார்.
Hello. Good evening, sir.
Good evening, sir. Please
very webinar, sir. It's very informative talk.
Okay, sir.
Sir, other than pituitary tumor, any other condition related to pituitary which can cause optic nerve damage, sir?
Oh, any other pituitary apart from the pituitary tumor?
Yes.
No, because it is next to this thing, it is mainly the tumors and cranios from a hypothalamus, craniopharyngiomas and other things. It's mainly tumor related only. It can happen apart from, I don't know, venous sinus thrombosis and other things. But I think it is mainly the pituitary tumors that can space-occupying lesion that can compress the optic tract and causes visual problems.
Thank you, sir. Thank you.
Thanks. Sir, close
If there
பண்ணிடலாமா,
are
sir?
no more interactions, then I thank Dr. Suresh for his excellent presentation, and a lot of interaction happened.
Yes, sir.
And
Thank you. At the end of the talk, we got 42 people, sir. That's good.
yeah, that's good. And I once again thank the President, Secretary, and Treasurer of our Coimbatore branch of IMA for arranging the meeting to be arranged under the banner of IMA. And all the officers of IMA were also present for the meeting. I thank them once again, and we will meet next time in some other meeting.
Okay, sir. Thank you.
Dr. Karna.
Dean sir and sir and sir, people keep roaming around, and we also roam around with the patients. Even this roaming in the patient, I think you need to present the module which you get. When you see a patient, this one should be at the back of your mind. So I can say,
Sure, sir.
MCQ, malaria, unless we have it at the back of your mind, we cannot continue. So the same thing, I think we should let us understand about the signs and symptoms should be in our mind. Modules and we can finish.
Thank you, madam. Thank you for your feedback.
Thank you for President and Secretary and Karuna madam. Thank you so much for joining.
Thank you.
Bye, sir. Have a good evening. Bye.
Bye.